Hello, everyone. Welcome to another session of Zooming Through ID. I am Dr. Gopal, an infectious disease specialist, trained at Duke University, been practicing in the South Florida area for a little over 20 years. I am a faculty for infectious disease at the Broward Hospital, Broward Health North. I chair the infection control committee, and I'm the director at Broward Health North for epidemiology, infection control. I chair the antibiotic stewardship program for the four Broward hospitals in the area. Teaching is one of my passions, and we are going to talk about syphilis today. This is part two, and the person who is doing the presentation is Dr. Janice Gomez. Did a excellent presentation. She did syphilis part one. You can listen to it, and now she's going to do part two. And Janice, I will give it. You can take over.
Thank you so much, Dr. Gopal. Thank you for being here again. Super grateful. Janice Gomez Garay, I'm PUI1 Internal Medicine at Broward Health. And I was covering syphilis part one, and we talked a little bit about, what is syphilis, this infection, the causes, why it's important, a little bit about we talked about the numbers, how it's been rising through the years. So basically, to give a little bit of recap, we talked about syphilis is a condition like an infection that happens because of a bacteria called Treponema pallidum. It gets transmitted through the mucosa, penetrates the body, and goes to the blood, to the organs. And it's important in the US specifically because from 2016 to 2020, the statistics show that the cases have been increased drastically from about 26% of cases have been going up through the years. And a lot of this is because of different social factors, also lack of education, people also changes in sexual behavior. And through this syphilis part one, we were able to see how are the stages of this infection. It is important initially because when the person has it, it can be very detrimental, even fatal. It has four stages, different stages. The initial stage, a primary, secondary syphilis, a latent phase, and also asymptomatic periods between the second stage, and the third stage. Tertiary syphilis being like the worst when it manifests into your body, the organs, and also we talk a little bit about the congenital syphilis, why it's important. As I was, we mentioned primary syphilis. If you guys remember, we have the chancre. Later, the person goes into an asymptomatic stage. Then they can have secondary syphilis if keep being untreated, mostly seen with the rashes in the palms and soles in the body, mucosal involvement, and also like a lot of lymphadenopathy. And tertiary syphilis, when it happens, well, there's the latent syphilis with the person is asymptomatic for many years, and then it stays latent. It can go back to the person can go back to revert to second stage, and the tertiary it affects mostly the deep organ tissues of like the heart, the brain, and many others. Why was this important? It's because it can be fatal at the end of the day for this patient. And we talked about the algorithm, how to treat it. If you guys remember, if we want to summarize it, we have to do serological tests, treponema or non-treponema, then confirm it with either of treponema or non-treponema, depending how you follow the algorithm. And if the patient it comes back negative, never let them go. You have to repeat it again 2 to 4 weeks, okay? And the treatment
Just,
basically.
Janice, just you. Just to touch up on the treponemal versus non-treponemal additional points. So the non-treponemal tests, the RPR or VDRL, and you mentioned about false positives. So some of the common reasons would be autoimmune diseases, viral infections, old age, or pregnancy. You can see some false positives. And the false negatives, you did mention in the previous talk about early stages, and there is a effect uh, Prosson phenomenon. That is what is seen in early infection. So it can be false negative. And so definitely, like you said, we have to always confirm, the treponemal test will be confirmed. The non-treponemal test, the titer will decrease, fourfold rise and decline after treatment is equivalent to cure. But the one point to make about the treponemal test, the FTA antibody test and the TP PA test is, the FTA is once reactive, they always remain reactive
Mhm.
even after appropriate treatment. So that is very important distinction to make. Yeah. Mhm.
Oh, here's the algorithm again so they can see it once again. Yeah, thank you for that addition, doctor. That's super important to know those details, that you see it in the day to day. So thank you for the addition of that. And basically, after that, the algorithm, we see how to manage it, diagnose it. We said like, oh, okay, the treatment is what? Penicillin, right? IM mostly, we have to be careful, what type of stage the patient is, early versus late. Some of them we have just the one shot, other of penicillin. Other stages we usually have to do more than that, usually three. And neurosyphilis has some specific treatment too. Okay, that we have to add. So we have to
And
review.
then the pregnant patients, very important to realize that even if they are allergic to penicillin, the pregnant patients, they have to be desensitized to penicillin. And they have to be, we have to make sure we treat them with penicillin and no other option. For the pregnant patients, not even ceftriaxone is an option. So because of the problems with the congenital syphilis that they see. Yeah. Mhm.
Yeah, like you mentioned, the vertical transmission, they can be get like
Any stage.
transmitted in, yeah.
Mhm.
That's super interesting. Okay, so with that, we finalized last lecture about the treatments, the importance of it in public health to treat it, to follow it up in these patients. And now let's apply it a little bit more. So it's important for us to see, to practice it and see what the board tests, but also what we see in real life. And before we start doing these questions, I wanted to share a personal story about a case I had during my when I was a medical student of syphilis in my family medicine rotation outpatient. So I had this patient that he came in one day and he told me, Doctor, so I wanted to check because somebody in my work told me I have two balls here. I was like, what do you mean to? No, I have two things really big here. I don't know what it is. When I see the patient, I do a physical exam, was a bilateral occipital lymphadenopathy. And I start asking him questions, about his sexual history, everything. And during, the interview, the patient reports that a few months ago or a few weeks ago, he wasn't sure of the timeline. He did note that he had a penile lesion, but it went away and he didn't thought it was anything. He was a male that has sex with male. He was at risk. He was not using protection. So he had, all the signs and symptoms. And when we ordered the test, they came back positive. So super interesting the way that he presented, because when I looked at his hands, was starting to have the rash, very, very faint in the palms, not much in the soles yet, but he was starting to have it. But this bilateral lymphadenopathy, I'm sorry, in the occipital area, I saw that it was super ideal also for syphilis. Usually bilateral, it can also be inguinal. So super cool case to share with you guys.
Ah, that's very interesting. Very nice.
Yeah,
Very interesting case.
yeah.
Very important. And the other thing is when ocular syphilis,
Mm.
If it is not treated, it can lead to blindness. So it's very important that if you're, if we are sending a patient to the emergency room, we need an ophthalmologist to come and examine the patient. I've had to send patients to ER, and then we have to have, so if they examine, if they have any signs of syphilis, we have to treat them. We don't need to wait for the lumbar. Like I mentioned to you, we don't need lumbar puncture or anything, ocular syphilis. If they have the high pretest probability, we have the serological testing, and if they have symptoms, it's curable with the treatment with penicillin. Yeah.
So, Dr. Gopal, for a patient like this that presented to me, and after that, with the bilateral lymphadenopathy, we sent him to treatment. We gave him his penicillin shot. Would you send them right after to ophthalmology just for evaluation, or not yet? Because he was not having any symptoms of
Oh, no,
like
no, no, no. I was talking about not this patient, but
Sunday.
the
Okay.
the staging of syphilis is very important. From what you're saying, that patient was his HIV test positive or no?
No, no, it was
So he
not.
probably was in earlier stages.
Gotcha.
And if he doesn't have any symptoms, then yeah.
No. Okay, perfect. Thank you for sharing that with us. So now let's get started with some of the questions. Mostly from mix up internal medicine. And let's get started here. So let me see if this moves a little bit here so you guys can see. So 26-year-old female woman is seen for follow-up discussion of test results. So 3 days ago, she was evaluated for a 1 week history of non-periodic rash that appeared to be resolving since the initial evaluation, which was a couple, like 3 days ago. A week ago, right? Patient report no recent history of oral or genital ulcer. She is transgender. She has multiple sexual partners, men and women, and reports consistent use of condoms except for oral sex. Medical history is notable for 2 instances of gonorrhea in the past year. Treatment for early latent syphilis 1 year ago. The medications are in combination that she has as tenofovir and emtricitabine, which is mostly used for HIV, and physical examinations or HIV or PrEP, like HIV prophylaxis too. Physical examinations, 100.2 fever. The other vital signs were normal. She had enlarged cervical, axillary, epitrochlear lymph nodes that were present. She had a faint erythematous maculus and papules spread through the trunk and the extremities. A few lesions noted on the left palm. The lab that she came in for to check and the follow-up was a RBR. This is the number 1 to 128. And the one that was 3 months ago was 1 to 2, the ratio. So the testing, urine and throat of the anal swabs for the gonorrhea and chlamydia were negative, and the HIV was negative. So based on these results of the test and what you got from the history and the physical exam, which of the following is the most appropriate treatment? We need to first identify what type of stage is this patient, right? And then figure it out if we're gonna give a single dose or the 3 doses. Sometimes these two are used, right? Remember the ceftriaxone and doxycycline, very rarely, but they can be used. So which one do you guys think it is? We'll see. Let's discuss it on the next slide. So let's see. You guys think it was the single dose? Yes, it was. Why? Because it's not still what? It's not still the latent state. It's likely presenting in the early symptoms of the disease, which sorry. No, 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 no. Let me see. No, sorry. Here we go. Sorry about that. We gave some answers away. So the single dose is more for the early stages versus the 3 shots is more for the latest. So if we read a little bit, the single dose most appropriate for a person that has secondary syphilis, so more early, right? Which she doesn't have like tertiary latent or like neurosyphilis, so more early between 1 or 2. In this case, she was secondary syphilis. presented with a rash that was resolving. So we were in the secondary stage, right? Because she already probably got the chancre months ago. Systemic symptoms, she showed the lymphadenopathy like my patient, but everywhere. You saw, remember the axillary, generalized, like the epitrochlear. There's also like absence of any genital lesion. So that doesn't exclude the possibility of syphilis because the chancres usually are painless and will heal spontaneously. So if you don't see it, it doesn't mean that she doesn't have it. Okay, if you don't see it in physical exam, you have to test for it. Because she has a history of syphilis, it is suspected that the enzyme immunoassay will remain positive because it's there, it's latent. However, a significant increase in the RPR titer indicates that there's a new infection, okay? So in this transgender woman with high risk of STIs, if she were unlikely to return for follow-up to the clinic for support and therapy before results, she wouldn't notice like she had this infection. So she should be counseled about the STIs related to the unprotected sex, like we talked about, counseling, and we need to follow up the syphilis serology, treat her, follow up the syphilis serology between 6 to 12 months, okay? What we will expect what happened in those after the treatment is a four-fold decrease in the RPR titer by the first year, by that year, the first 12 months. Additionally, it will be appropriate to discuss like further use of possible doxycycline post-exposure prophylaxis. That was something that I remember I learned after because I didn't know we could do that. So super interesting. And the self-administration of that doxycycline within 72 hours of having unprotected sex. Other than that, the 3 doses, like we talked about, is usually for latent or syphilis of unknown duration, like Dr. Gopal mentioned, and the also used for neurosyphilis. We have, if you guys remember, the other regimen that includes sometimes probenecid, and even there was the extra one that they use ceftriaxone in certain cases. Okay, so it's a really cool question. This is the second question. 30-year-old woman, pretty easy, evaluated for painless lesion on her vulva. We see it there. What is this? This is the chancroid, okay? I just wanted you guys to identify it the way that it looks. Usually like the base is just like this, very like circular form, circumferential usually located. So I sorry, is the
Syphilis. It is actually painless versus painful. That is, yeah.
exactly.
Yeah. So the distinction here is, the syphilis is usually painless
Mhm.
syphilis. Syphilis is painless. Granuloma inguinale is painless. And LGV is also painless, but the lymphadenopathy that you see in the LGV is painful. So the painful ulcerations would be HSV, herpes simplex. Chancroid is painful, very painful. And monkeypox is also painful. So the key in this question is this was a painless.
Yeah. I
So,
was referring like to identify like the first stage of syphilis that we have the chancre, but
mhm.
I confused the word with chancroid. But yes, chancroid.
Ulcer,
No,
yeah.
sorry.
Painful ulcer.
Chancroid will be the one that you mentioned, the like
The
first way.
chancroid will be painful. Yeah.
Yeah.
Distinction.
Okay, so pretty easy. The ulcer, approximately, this patient is probably in a first stage, based on the physical findings. So approximately within a month, she got the primary chancre. She got infected. So let's see. Here we have something different, maybe. Let's see. Who knows? 25-year-old woman evaluated for fever, generalized lymphadenopathy, painless genital lesions shown. And we have multiple. Let's see. Which of the following is the most likely diagnosis? Beta syndrome, genital herpes simplex virus infection, the human papilloma virus, or the secondary syphilis. So what do you guys think? 1, 2, 3 seconds. You got this. Secondary syphilis. Don't get confused. Yeah, this patient had a lot of lesions, but don't get confused with the herpes. Let's see, painless. Remember, Dr. Gopal just mentioned it. So this patient also, if you guys noted, sorry, I don't know where it goes back. Let me see. This patient also has some condyloma lara. We can, well, difficult to appreciate a little bit, but the patient has condyloma lara. These lesions involving the vulva and anal region are caused also by Treponema pallidum. So this likely diagnosis is more like secondary syphilis. It's a manifestation of secondary syphilis. So remember the rash. It's not always the rash in the palm and sole. There's other things,
Fluid,
okay?
moist, warm areas. Yeah.
All the mucosa.
Mhm.
So the clue again is painless. These ones were gray raised papules involving the vulva, the anus, or the genital areas. And these are typically located near the primary chancre. So that's the clue. So don't get confused. Remember that painless and painful, and don't get confused also of the single lesions, because you can have the single lesions and these around it, okay? Next question. 44-year-old male is evaluated for progression of difficulty with ambulation and numbness. Numbness in his feet and hands started 4 months ago and has moved up his arm and legs. On physical examination, vitals are normal. Sensory perception of pain and vibration is diminished in a stocking glove distribution. And deep tendon reflexes are absent throughout. Cranial nerves and cerebral examination findings are unremarkable. Bilateral muscle strength and mildly reduced in the deltoid, biceps, tibialis anterior, and moderately reduced in the psoas, quadriceps, and gastrocnemius. So upper extremities versus lower extremities. We see the differences, right? Mild and moderate. CSF studies showed they did the CSF leukocyte as 5, 5 times the liters, and the protein is 420 milligrams per deciliters. A lung antibody test result were negative. Serum and urine immunofixations results with the A1C and serum vitamin 12. Serum copper levels are normal. And electromyogram reveals sensory and motor demyelinating neuropathy with prolonged nerve conductions latency and without axonal changes. MRI of cervical and thoracic spine is unremarkable. So which of the following is the most appropriate diagnostic test to perform in this patient? So super interesting question, especially this part. We gotta make sure that what they're ruling out is involving what? More the nerves, more possibly the spine, right? Because we're seeing like a lot of like weakness. They're telling us some negative findings, trying to tell you, hey, it is not this, it's not vitamin B12 triad that causes the neuropathies, it's not anything related to copper. Okay, so let's see what it is. What do we do? HIV test. Why? What do you guys think this patient has? Probably what? Syphilis, right? And usually, syphilis and that, well, if you feel the patient has like sexually transmitted disease, the first step that you actually have to do is HIV. But let's go a little bit to the explanation, and then we'll go to the key points. So the most appropriate test to do, remember, is the next best step. Is HIV because this patient has a chronic polyradiculoneuropathy, and you test first for HIV, and the clinical course, based on what it was described, includes like asymmetrical, proximal, and distal sensory and motor deficits. Diffuse areflexia, demyelinated neuropathy on the electromyogram, and the albuminocytogenic dissociation with elevated protein.
Yes. That's
Yeah.
it. Yeah. Uh-huh. Uh-huh.
No, go ahead. Do you want us to say something?
No, no, I'm saying albino cytological dissociation. That is a,
Super important is
yeah.
the elevation of protein from the normal.
Mhm.
So you see the you compare the protein in the CSF, and when you do the difference, will be mildly elevated. Basically, that with the normal protein and the albumin. And this is consistent with like a chronic inflammatory demyelinated polyradiculoneuropathy. Since this progression has been like over like more than 8 weeks or so, this is consistent with this chronic inflammatory demyelinating polyradiculoneuropathy versus Guillain-Barré. It seems also like Guillain-Barré, right? Like the symptoms. But however, the symptoms in Guillain-Barré will be more like early that you will experience it early when you get exposed to the infections 4 weeks. So the other important things, you need to isolate to diagnose this. You need to isolate it from other conditions. So you need to rule out diabetic neuropathy or like anything related to cancers and an HIV infection, because all these patients can present very similar with these neuropathies. Um, what else? That's pretty much it. I don't know if you have anything else to add. Also, well, the syphilis part. So the syphilis, if you, I don't know if you guys remember the image that I sent, show you guys in the first session, that included like the secondary syphilis, tertiary syphilis. So can cause posterior cord myelopathy, like the tabes dorsalis that they mentioned, if I recall correctly, the name with or without axonal polyneuropathy. And in this case, the demyelination on the EM and the CSF albuminocytologic dissociation makes syphilis unlikely, because syphilis will what? In the first lesson, we learned it will increase your protein or increase your white count.
Happy disease.
But so
Yeah.
you
Syphilis
have
causes pleocytosis, so we don't see that. And here it's more like albuminocytological dissociation. So that's one of the key differences. Yeah.
so unlikely diagnosis, and also you don't have to do the troponemal testing in this case, based on what the boards say. But I think in the practice we actually will do all of them. Okay. And 24-year-old male undergoes a consultation for test results following an empiric therapy with ceftriaxone and azithromycin for sexually transmitted proctocolitis 3 days ago. His symptoms of mild rectal pain, tenesmus, and discharge are improving. So he got the antibiotics, these two, ceftriaxone and azithromycin, and he's following. Okay. Medical history includes no prior diagnosis of STIs, and he takes no medications. And his nuclear amplification test for chlamydia is positive for chlamydia, negative for gonorrhea, and herpes simplex virus. The syphilis enzyme immunoassay is positive with a negative RPR. So they had to do the fluorescent treponemal absorption to confirm, and it's positive. So HIV serology, they did it, it's negative. So what is the most appropriate treatment? So like I was mentioning, he did have, right, the positive chlamydia. He does have an amplification test. The syphilis immunoassay is positive, and the other one, remember, treponemal, not treponemal, is also positive. So what do? Penicillin. And the key point is here that without a history of prior syphilis or treatment, the patient has a positive test, and you do the confirmatory, like we mentioned, and it was positive. So positive and positive, you have to treat because you confirm it. It's not a false positive. So in this case, will be, since a new one, he didn't had anything prior, will be the single, well, the once weekly. I'm not sure actually. Wait, why they're saying it's a once weekly dose in this case? Let's go back real quick. Oh, oopsie. what happened here? Here we go. Because usually we do the three
They
dose.
don't say they just say the Benz. We pick one choice. Benz.
Ah, exactly, exactly.
That's
Okay. Yeah,
yeah.
it doesn't have to be the three doses per se. Perfect,
Yes.
perfect.
Because this patient, we don't know. The patient was never treated. So remember, I told you the FTA wants to remain positive. It remains
Yeah.
positive. Yeah.
Mhm.
So this he definitely needs treatment.
So yeah, it's much easier just like selecting the penicillin. That's the important
That
thing.
is a choice. Yeah. Mm.
The other thing, let me see if there's anything important here. Yeah, like we mentioned, those with confirmed tests should be a no history. No history should be offered the treatment with their duration here. The NAT test, we have to use it for confirm. We can, like we mentioned, we have confirmed with either
Bronchitis. Yeah. Chlamydia. Hmm.
for the chlamydia and also start empiric treatment for that. So he already got it. Okay. Let's continue. And oh, actually, oh, that was the last question. Oh, so sad. It was fun. So that was the last question of to practice a little bit and add some other points. So a little bit of summary, right? To close this topic, so interesting topic out. So syphilis is a curable sexually transmitted disease and it's caused by this treponema bacteria that with early detection and treatment is super crucial to prevent all this complication in the later stages. And it's easy to screen, it's easy to prevent, and we have to do our work in from our end as doctors, a primary care physician, the first line for these patients for education to give them the access of this education and help them understand why this is happening, help them prevent it. And if sadly they are not able to prevent it, then treat them early on to avoid all this complication. So the call to actions, basically, I wanted to mention, for this resurgence that happened in the US, that this disease had been for such a long time in the history, and having a resurgence of something that can be prevented is very scary because we want to maintain this in the lowest levels possible in the population. So it requires greater awareness, education, better prevention programs, more public health and prevention strategies, expanding the access to healthcare for the patients that needs it and the most vulnerable population, and from the epidemiology standpoint, efforts a lot to control the epidemic when it happens and prevent the further spread with all these strategies. So with that, I want to close this topic. I don't know if Dr. Gopal has anything else to add. And these are my references. This first study, the modern epidemic of syphilis, was like the base study for this presentation. If you guys want to check it out, here's the reference. And we have other things, especially the Center of CDC's control. We have to report it. So they have a lot of information, a lot of data if you guys are interested in research or syphilis in general to learn. So I'm super happy to be here. Very thankful to Dr. Gopal for this opportunity. And if there's anything else to add, if not, I can close with that.
Yeah,
Thank you.
this is a wonderful presentation. And Dr. Ghanem, I mean, your first reference, I mean, he's the best in terms of the syphilis, and it's a great article that you have as reference. So it was a very interesting talk. I mean, Janice, you did an excellent job and very thorough. And as you mentioned, you all are going to see a lot of cases of syphilis, different testing, different patient scenario, different stages. So this is all going to be very useful. And this was wonderful presentation. And one thing to remember that we have many bacteria that is becoming smarter and having different resistance patterns, but Treponema pallidum we can still treat with penicillin. So just be aware of that. Look out for your case and do the right thing, stage correctly, treat it properly. Thank you all for joining.
Thank you, Dr. Gopal. Take care, everyone.